It's my pleasure to talk today about hereditary ataxias. So first of all, let's define ataxia. It's the absence of voluntary muscle coordination and loss of control of movement with gait instability and limb incoordination. We can also have nystagmus and dysarthria. Cerebellum plays a fundamental role in coordination, and ataxia is usually caused by cerebellar dysfunction or impaired vestibular or proprioceptive afferent input to the cerebellum. Ataxia can be caused by either genetic or non-genetic causes. In fact, whenever we have a lesion in the cerebellum or its associated systems, we can have ataxia. So the lesion can be a tumor, inflammation, infection, and so on. Here, we'll focus on the genetic causes of ataxia. So hereditary ataxias are progressive neurodegenerative diseases affecting the cerebellum and its associated systems. The spinal cord and the peripheral nervous system are also frequently involved. They are characterized by a high heterogeneity with different modes of inheritance, which can be autosomal dominant, autosomal recessive, X-linked, or mitochondrial. Here, we'll focus on the most frequent causes of hereditary ataxias, which are the autosomal dominant forms, also called spinocerebellar ataxias, and the autosomal recessive forms. So let's start with the autosomal dominant forms. SCAs, or spinocerebellar ataxias, are rather rare. They are late onset diseases with the onset of ataxia often in the mid-adulthood, typically in the 3rd or 4th decade. Frequently, we observe an atrophy of the cerebellum. Other parts of the nervous system can also be involved, such as the spinal cord, the brainstem, basal ganglia, cortex, or peripheral nerves. Autosomal dominant cerebellar ataxias are highly heterogeneous, and to date more than 40 distinct genetic forms have been identified. They are classified according to the genetic loci in order of identification. So the first identified form was related to the ataxin-1 gene on chromosome 6 and referred to as SCA1. SCA2 was the second identified form related to mutations in the ataxin-2 gene on chromosome 12, and so on. Here is an old classification. It's the Harding's clinical classification of autosomal dominant ataxias. It's still useful in the clinical setting. Type 1 describes cerebellar ataxia with variable additional signs. In type 2, we have cerebellar ataxia with macular degeneration causing progressive visual loss. And type 3 refers to pure cerebellar ataxia. Most of the genetic subtypes of SCA manifest clinically as type 1, more rarely as type 2 with a pure cerebellar syndrome, and type 2 consists of only SCA7. Mutations in autosomal dominant ataxias are mainly repeat expansions, either intronic or exonic. The most frequent forms, which are SCA1, 2, 3, 6, and 7, which represent about half the cases, are related to a CAG repeat expansion in a coding exon. CAG repeat expansion leads to translation of expanded abnormal polyglutamine repeat, causing protein misfolding and aggregation, which lead to cell toxicity and various cellular process dysfunctions. Intronic repeat expansions causes the binding of regulatory binding proteins, or BP, to abnormal RNA with a toxic RNA gain of function. Repeat expansion mutations are unstable. They increase in size from one generation to another, leading to more severe disease and an earlier age of onset, which is referred to as an anticipation. So when we have a clinical evidence for SCA with progressive ataxia, no evidence of acquired cause, and similar disorder in preceding degeneration, and if we have a highly suggestive phenotype or a high regional prevalence of a particular type of autosomal dominant ataxia, we can perform a targeted gene test. Otherwise, we will screen for the most frequent mutations, which are translated CAG repeat expansions, And if negative, we can then screen for the untranslated repeat mutations or perform whole exome sequencing. Here is the case of a 21-year-old man who developed progressive ataxia at the age of 16. His father had the same complaint with a disease onset at 35 years. So as you can see in the video, the patient has an ataxic broad-based gait and also limb ataxia with dysmetria. So a typical cerebellar syndrome. His MRI showed a marked cerebellar atrophy. So in this patient, we have a clinical evidence for spinocerebellar ataxia with an anticipation phenomenon. In fact, the patient had an earlier onset as we compare to his father. Associated with ataxia, the patient had a particular phenotype with ophthalmoplegia. As you can see here, he can't move his eyes laterally or vertically. So he has lateral and vertical gaze palsy. This phenomenon is this phenotype is highly suggestive of either SCA2, SCA3, 28, or 40. As types 2 and 3 are the most common, we screened for them by performing a triplet repeat primed PCR, and we identified heterozygote CAG expansion in the ataxin-2 gene. So this patient had SCA2. Let's consider now the autosomal recessive forms of cerebellar ataxia. Harding's clinical classification defines 3 types of autosomal recessive cerebellar ataxia. The first described one and the most common one is Friedreich's ataxia. In this disease, we have, unlike in the autosomal dominant forms, an early onset, usually before the age of 25. Progressive ataxia is associated with dysarthria, loss of lower limb reflexes, deep sensory loss, and pyramidal signs with extensor-plantar responses. In fact, Friedreich's ataxia is mainly a disease of the spinal cord. We observe degeneration of the dorsal root ganglion and dorsal spinal columns, which are sensory pathways, which causes deep sensory loss and abolished lower limb reflexes. We also observe degeneration of the pyramidal tracts, explaining the Babanski signs. And cerebellar ataxia is related to the degeneration of the spinocerebellar tracts within the spinal cord, but also to lesions in the dendrite nuclei in the cerebellum. Besides Friedreich's ataxia, Harding described an early onset cerebellar ataxia with a variety of signs we don't observe in Friedreich's ataxia, such as retained tendon reflexes, myoclonus, deafness, and so on, and also an autosomal recessive late onset ataxia form. So what about autosomal recessive ataxias in our region? As you know, consanguinity is a major risk factor in the occurrence of autosomal recessive diseases, and as we have high rates of consanguineous marriage in our region, we expect to have rather frequent autosomal recessive forms of ataxia in our region. So early onset ataxias were studied in our institute in the 1990s, and the presence of various phenotypes, even within siblings, was observed. So the application of Harding's clinical classification was impossible. Linkage analysis was performed in 5 Tunisian large inbred families with Friedreich's phenotype using microsatellite polymorphisms. 3 families were linked to Friedreich's locus on chromosome 9, but 2 families did not show the expected linkage. On subsequent analysis, all these patients had very low levels of serum vitamin E. And this was the first report providing evidence for genetic heterogeneity for the Friedreich's ataxia clinical phenotype. Subsequently, linkage analysis was performed in these families with Friedreich's ataxia phenotype and vitamin E deficiency using microsatellite markers on chromosome 8, 9, and 20. And homozygosity mapping allowed the localization of this disease to chromosome 8. 2 years later, the gene encoding a transfer protein of the alpha-tocopherol, which is the major active form of vitamin A, was mapped to the same region on chromosome 8. And direct sequencing of this gene showed frameshift mutations in the patient with Friedreich's ataxia phenotype and vitamin E. So these studies allowed the individualization of a new disease called now AVID, or ataxia with vitamin E deficiency. Since then, more than 40 genetic forms of autosomal recessive ataxias have been identified. They either show a typical Friedreich's ataxia phenotype or a different phenotype with other clinical features associated with ataxia. We can also classify these diseases according to the pathogenic mechanism. So they can be mitochondrial, such as Friedreich's ataxia, metabolic, such as AVID, related to DNA repair defects, such as ataxia telangiectasia, or ataxias with oculomotor apraxia, or due to protein folding defects, such as in ARSACS. Here, we've performed a genetic study of about 400 Tunisian patients with autosomal recessive ataxias. And unlike Western countries, where Friedreich's ataxia is the most frequent form, ataxia with vitamin E deficiency turned to be predominant in Tunisia, accounting for about 44% of cases. So let's take a closer look at AVID. AVID has been reported worldwide, mainly in the Mediterranean region, in North Africa, but also in Italy. Here's the largest reported study on AVID, including 132 patients belonging to 49 families. All patients had low serum vitamin A levels with normal serum vitamin E levels. Several mutations in the alpha-tocopherol transfer protein have been identified. In this study, we screened for the 744del-A mutation, which is a founder mutation in North Africa. If this mutation was absent, direct whole gene sequencing was performed. This mutation was found in the majority of patients, in up to 91.7%, and 3 other different mutations were also identified. 744del-A is a frameshift mutation resulting in a truncated protein. Patients harboring this mutation have a normal gastrointestinal absorption of alpha-tocopherol, but an impaired ability to incorporate it into very low-density lipoproteins secreted by the liver. So there is a loss of the efficient recycling of plasma vitamin E. The mean age of onset was 13 years old and ranged from 2 to 37 years. It's a slowly progressive disease, and only 10 patients were wheelchair-bound after 8 to 19 years from the onset of the disease. Head trauma was present in 40% of the patients. Ankle and knee reflexes were absent or weak in more than 90%, and skeletal abnormalities such as ischias or kyphoscoliosis and hamartosis were frequent. Retinitis pigmentosum was observed in 4% of cases. So here is a 44-year-old AVID patient with a disease onset at the age of 18 years. As you can see, he's ataxic with a broad-based gait. He had also upper limb dysmetria with the and also the characteristic head dystonia and tremor. We don't usually observe in Friedreich's ataxia, but we usually observe in AVID. Most of the patients exhibit mild or no abnormalities in the nerve conduction studies. On MRI, AVID patients can show an atrophy of the cervical spinal cord. Here is a neuropathological study of a patient with AVID. We observed demyelination of the spinal sensory system, neuronal loss, and lipofuscin accumulation in the spinal horns and posterior root ganglia. In this prospective study, patients were supplemented with vitamin A during 1 year period, vitamin E serum levels normalized, and we observed significant clinical improvement, especially when disease duration was short. So identifying AVID was very important, as it's one of the rare curative causes of hereditary ataxias. Friedreich's ataxia was the second most common cause of autosomal recessive ataxia in our study. So let's see it in more details. It's frequent in Europe and North Africa. It's an early onset as Friedreich as AVID, with a mean onset at 10 to 15 years, and it manifests as progressive ataxia, dysarthria, areflexia, Babanski signs. Friedreich's ataxia is caused by mutations in the frataxin gene located on chromosome 9. The main mutation is a GAA triplet expansion in the first intron of frataxin. In most cases, patients are homozygotes for the expansion. More rarely, they can be compound heterozygotes and have the GAA expansion in one allele with a truncating or missense mutation in the other allele. The presence of a large GAA repeat expansion leads to frataxin gene silencing by two potential mechanisms. The first one is that the GAA repeat may adopt abnormal non-B DNA structures called triplexes or DNA-RNA hybrid structures called R loops, which impede the process of RNA polymerase and thus reduce frataxin gene transcription. The second mechanism is increased level of DNA methylation and heterochromatin protein 1, which trigger heterochromatin formation and lead to more pronounced frataxin gene silencing. Frataxin is a mitochondrial protein involved in assembly of iron sulfur clusters. Its deficiency causes mitochondrial dysfunction with dysregulation of iron metabolism and oxidative stress. The identification of the mutations causing Friedreich's ataxia allowed the broadening of the disease spectrum. In fact, up to 25% of the patients with Friedreich's ataxia don't fulfill Harding's criteria, as they have a typical phenotype with late or very late age of onset or with retained reflexes. The age of onset correlates with the GAA triplet repeat size in the shorter expansion. When the expansion is small, the age of onset is late. It's important to distinguish Friedreich's ataxia from AVID, but clinically they are very similar, although head tremor seems more frequent in AVID. Peripheral neuropathy is usually severe in Friedreich's ataxia, as illustrated here, but with an important reduction of fibrous density on the nerve biopsy. Conversely, here in a patient with AVID, there is only a slight reduction of large fibers with regenerative axonal sprouting. Moreover, Friedreich's ataxia is a multi-system disease causing diabetes and cardiac dysfunction. In AVID, these complications are rather rare. Another disease resembling Friedreich's ataxia and AVID is A-beta lipoproteinemia. It's a rare disease resulting from mutations in the gene encoding the microsomal triglyceride transfer protein, MTTP. In this study, the patients were found to be homozygous for a truncating nonsense mutation and for a splice mutation. Typically, the patients present with chronic diarrhea and failure to thrive, with progressive ataxia starting in the first to second decade. MTTP is required for assembly of VLD in the liver and chylomicrons in the intestine. In these patients with MTTP gene mutations, we find low levels of cholesterol and triglycerides with almost complete absence of apolipoprotein B containing lipoproteins. We can have also deficiency in lipid-soluble vitamins such as vitamin A and A. Till now, we've seen autosomal recessive ataxias with Friedreich's ataxia phenotype. Let's consider ataxias with different phenotypes and start with spastic ataxias and ARSACS. So ARSACS was first described in Canada, but it has also been reported in other regions worldwide. It's caused by mutations in the gene encoding Sacsin, the chaperone protein involved in the ubiquitin proteasome system. The founder mutation was identified in Canada. In these 4 reported Tunisian families with ARSACS, each showed a different mutation. The mean age of onset in ARSACS is 2 years. It's characterized by a progressive spastic ataxia with brisk tendon reflexes. We have usually a severe neuropathy and increased visibility of the retinal nerve fibers. MRI shows cerebellar vermis atrophy and a very characteristic sign found in most cases, which is T2 hyperintense pontine striations. Another different phenotype is ataxia with oculomotor apraxia. We'll focus here on the type 1 and type 2. So just to show you what is oculomotor apraxia, here's the patient with this type of apraxia, which corresponds to the disruption of eye-head coordination. And as you can see in the video, the eyes start moving before the head. So let's start with ataxia with oculomotor apraxia type 1. Ataxia with oculomotor apraxia type 1 is the most frequent cause of ataxia in Japan. It's caused by mutations in the gene encoding the apraxine protein, which is involved in DNA repair. Several different mutations have been reported. Here's a Tunisian study of 13 patients. 2 mutations were found, a splice mutation and a complete gene deletion, which surprisingly did not correlate with disease severity. Brain MRI showed marked cerebellar atrophy in all patients. The mean age at onset was 5 years. Oculomotor apraxia was, however, not constant. It was observed in 77% of cases. All tested patients showed hypoalbuminemia and hypercholesterolemia. And then let's see type 2. So type 2 was first described in Pakistan and reported also in the MENA region. It's caused by mutations in synataxin gene encoding RNA DNA helicase involved in DNA repair and RNA metabolism. Synataxin gene was screened by direct sequencing in 5 Tunisian families. 4 different homozygous mutations were identified. The disease onset in type 2 was much later than in type 1, with a mean age of onset of 15 and a range from 10 to 20 years. Oculomotor apraxia was observed in 70% of cases. MRI showed vermiscent cerebellar atrophy. Nerve conduction studies showed constant severe neuropathy, and serum alpha-fetoprotein level was elevated in most cases, so it's an important biological marker of the disease. Then we've considered families with autosomal recessive ataxia, in which 16 loci were excluded. In 4 of these Tunisian families with autosomal recessive ataxia of unknown origin, whole exome sequencing showed homozygous mutations in the beta-2 beta-glucosidase 2 gene. 2 nonsense truncating mutations were identified, and the substitution predicted to alter protein structure and effect a conserved residue. These mutations were confirmed by Sanger sequencing, and none of them were present in 50 Tunisian controls and in 330 African, European, and Asian controls. So these studies showed the identification of a new gene implicated in autosomal recessive cerebellar ataxia. Beta-glucosidase 2 cleaves the sphingolipid glycosylceramide into glucose and ceramide. The accumulation of glycosylceramides in the neuronal cells would change calcium homeostasis and lead to neurological symptoms. Onset in GBA2 disease was during childhood or early adulthood. The course of the disease was slowly progressive. The phenotype was that of a spastic ataxia. In fact, all individuals had spasticity in the lower limbs, brisk reflexes, and Babanski signs. And nerve conduction studies showed axonal neuropathy. To sum up, when we have clinical evidence of autosomal recessive ataxia, we need to determine the specific phenotype. If it's a Friedreich's ataxia phenotype, ataxia with oculomotor apraxia, or spastic paraplegia, and to screen for biological or radiological biomarkers such as low vitamin A level found in AVID, elevated alpha-fetoprotein levels that we can find in ataxia with oculomotor apraxia type 2, or T2 hyperintense pontine striation on MRI suggestive of ARSACS. That would allow us to perform a targeted gene test. Otherwise, we can perform gene panel or whole exome sequencing. Finally, here's a Tunisian consanguineous family with autosomal recessive ataxia caused surprisingly by 3 distinct gene defects. We have in the same family AVID, ARSACS, and Friedreich's ataxia. So we need to take this into consideration in our high inbred populations and genotype all affected members, not to miss a treatable cause such as AVID. So here are some nature scenes from Tunisia. As you can notice, nature is as diverse as genetic in Tunisia. I hope to welcome you in person here soon, and thank you for your attention. Thank you.